So we shall start with our debate with Dr. Bhaskar Srinivasan, who's now on a different journey, consultant cornea, and in a very brand new private practice, which is going to keep Madras even more feature for talking around. And he's going to be debating on Dalk Big Bubble. I'm not making the introductions big because I would want you all to get to the content. And Bhaskar Srinivasan again is another veteran cornea surgeon of long standing who doesn't need any description, is a globally famous person. And debating against him is going to be Dr. Vikas Mittal. And he would be telling us why he would prefer a manual Dalk. And he's again cornea consultant at his cornea transplant surgical center, LGI Institute, Ambala City. Again, who is a very innovative surgeon, who comes up with novel approaches in doing corneal surgery even better. So on to you, Dr. Bhaskar.
A very good evening, one and all, and thanks, Doctor, for the introduction. So I'll start with my talk. So the debate is between a big bubble Dalk versus manual Dalk. I don't think there's actually a debate because you would need to be well versed in both, because it's unless you're Dr. Fogla or somebody who's so well versed that he gets a big bubble in more than 90% of these cases, we probably have to have an understanding of both techniques. Having said that, I would probably opt for big bubble as the first choice of Dalk unless there is a contraindication to it. No financial disclosures here. Some of the photos or the videos would be from the time that I have managed patients at SN. So in fact, in terms of keratoplasty, we've started from lamellar keratoplasty to penetrating keratoplasty, and now we are back to a compartmental kind of procedures as such. And we all know the advantages that Dalk has over a conventional keratoplasty. And the reason why a lot of us don't do Dalk is because we feel it's tedious, it's time consuming, it's challenging, and you might as well get a PK done in half an hour's time rather than spend that extra 20 minutes, 25 minutes getting a Dalk done. And the other thing would be reaching the correct depth or the interface, because if you are not deep enough, you will end up having interface haze, and that will compromise the vision. So for a best outcome, you probably need the deepest possible interface. You need the posterior layer of uniform thickness. You need a smooth donor and a recipient bed. The other factors in terms of coaptation of the edges, uniform traction of sutures, clean interface occurs both in big bubble as well as in manual. But when you're looking at these three first properties, deepest possible interface, uniform thickness, and the smoothest bed, that happens only with a big bubble, either a type 1 or a type 2. But a type 2, there is a higher risk of perforation. So we are probably looking more at a type 1 so that the risk of the surgery also reduces. So when you're looking at reaching the deepest interface with respect to Dalks, you have various techniques which have been described. And the most common is probably the big bubble and nowadays the groove and peel, which seems to be common. But manual is basically with respect to doing a layer by layer dissection. So you can see the video here, and this is a video almost about 10, 12 years back. We were using a needle and we can get a good bubble. And once that is done, we make a nick, a brave slash, and we are able to achieve a very smooth Duas layer, and the outcomes are good. So you have a very deep plane of dissection, you have a smooth recipient bed, and if you get a big bubble, the surgery is over in 45 minutes as such, as fast as a PK. And you would probably get the best visual acuity and at the fastest rate that you can have with any lamellar, anterior lamellar procedure. But the problems is the depth of placement of needle. We are worried about perforation, or we are, if it is too superficial, we get a stromal emphysema. Most of us are scared to make the big brave slash. And when we are dissecting it closer to the DM, we are worried about causing a perforation. With our better understanding and advances, we now know we can plan the surgeries better, so we can have a predetermined depth of the initial trephination. And anterior debulking makes sure that our needle is at a deeper plane. And instead of using a needle, using a 27 gauge blunt cannula reduces the risk of perforation during your insertion of the creation of the big bubble. Using a bit of Helon at the site of the brave slash prevents the immediate collapse, so you're less concerned with a DM tear. Also, marking the area, make sure that you are not left searching for your area of entry if your initial slash was very small. and the use of a visco big bubble to kind of make sure that it stays a little bit separated for your dissection. So all these have actually made big bubble a lot more safer and a lot more predictable and faster as compared to a manual dissection. So this is a recent video a few years back where you're using a predetermined depth knife. You're doing an anterior debulking to remove the stroma. So you're now sure. This is Foglar's dissector where you're kind of creating a tract. And then with the cannula, you go in. Now, because the cannula is blunt tipped, you can go in more bravely and you reach the paracentral area. And once you're there at the paracentral area, and you inject air, there will be a formation of a big bubble in almost about 80 to 85% times, as long as you are deep enough. And the ease of your entry of your spatula tells you how deep you are. Once this is done, then you need to have a brave slash, which you can make either with a microkeratome, with angled MVR or with a 15-degree. And once that is done, rest of the surgery is over in no time. The only thing is, during this time, your BP is probably at the highest. That's the only difference between the when you're doing a dissection of a manual dissection versus a big bubble, because you are bang on the Duas layer, you need to be even more careful. But there are some situations like this with the pediatric patient where we debulk the anterior surface, we tried to initiate a big bubble. We got a type 2 big bubble, which is basically more of a glassy bubble, and it is below the Duas layer. So because of the anterior haze, we are not able to make out, but you can actually see the whitish ring forming, and then you can actually see there is a glassy end. It's not like the white emphysematous bubble that you saw. So in these cases, you might probably be safer on to just do a manual peeling to make sure that you don't end up rupturing it. So like I said in the initial part of the talk, it's not whether you would want to do a big bubble versus whether you would want to do a manual. You would need to be well versed in both. And here we just opened up the plane, removed the air, and then did a Dalk. So the advantages, again, to reiterate, is a smoother interface, a faster surgery, a best visual recovery, and a fast visual recovery. Obviously, if there are tears or scars in the DM, then they are not a candidate for a big bubble. And when looking at literature, there are various reports, right, in the initial reports where they said that, yes, a big bubble has a better visual acuity. There are newer reports which say that the visual acuity is almost similar, but uniformly, all of them say that big bubble Dalk gives you a much faster visual recovery. And there are studies which have looked at even, say, less than 50 microns residual bled and said that the visual outcome in big bubble is slightly better than Dalk, and the densitometry measures with big bubble is much better than a manual Dalk, and the densitometry is almost similar to a PK, whereas that doesn't reach that same value in manual Dalk. To conclude, big bubble is my preferred technique, but I would always keep manual Dalk as a backup. Thank you.
Thanks, Dr. Bhaskar. That was a very crisp talk. Shresh, would you shall we finish the debate and then take the questions?
Yeah, we could probably take both together so that each pros and cons can be discussed.
On to you, Dr. Vikas.
Yeah, thanks so much. Can you see my slides?
Yes.
Okay, great, fine. So thanks so much. First of all, it's a fantastic platform. So what I'm going to do is I'm going to share my experiences with manual DLK. So I'll show you a few videos, few cases, and then I'll go through a few literature as well. So I did my first DLK in 2008, which was 2 years after my fellowship. And my first DLK, all of them had to be converted into PK, and these were all, I was trying to do big bubble, and I couldn't do all those things which Bhaskar has shown. And after that, I stopped DLK. I thought that I'm not a good DLK surgeon. In 2009, next year, I happened to visit Dr. Paras Mehta, who showed some beautiful post-DLK post-op patients. And I asked her that, I'm finding a lot of difficulty in it. She said, Vikas, just keep this bubble out of your mind and you'll be able to do a successful DLK. Next year, I restarted DLK, and in the last 10, 12 years, I've done close to 80 DLKs, which actually is only 3.5% of total corneal transplants. And most of these DLKs has been manual DLK. This is how we do the surgery. First is that, the trephination, with Trefine, I make only the mark, and then I use 250 micron fixed depth knife to make that groove. then remove the anterior stroma, the anterior debulking. This can be done very fast. And after that, the second layer is removed after we have decompressed it a bit. This fluid also tells us how much fibers are actually remaining. While dissecting the second layer, it is important where you are cutting. You need to cut these fibers which are attached to the flap, which I am holding, and not at the stromal bed, that with attachment, so that you don't end up in having any perforation. Here, the speed becomes slightly slow. The third layer, it's, it is easily visible that these fibers can be easily peeled off. So you are sure that you are in the posterior stroma, posterior stromal area. And after this, the same steps, the preparation of graft, the remove that endothelium, desperate membrane from the graft, and then you place it with any suturing technique. I like 16 nylon sutures. The suturing pattern is absolutely same as PKP. Just you need to ensure that the fold that you see, keep on pushing it after 4 sutures to the periphery, so that you don't see these folds in the center and doesn't cause any problem. You check, ensure that you have seen with your flaring Mallin's ring, and the surgery is over. So here are a few post-op patients. This is 3-week post DLK for keratoconus. If I zoom this photograph, see, it's hardly visible. This interface is hardly visible if you see even at 3 weeks time. So this is another patient of DLK for keratoconus. This was the first POD. It was quite edematous, which cleared off at the next follow-up, that is at the 4-week, and it was absolutely fine. So is it that all first POD of manual DLK looks like this? The answer is no. Another first POD of manual DLK, I think it depends on what is the graft thickness when you are starting. If you have a compact cornea, the first POD will look something like that. Even though that edema clears off pretty fast, this is 2 weeks post DLK, 5 weeks, 8 weeks, and when you see even the OCT, you have to really work hard to see where is that interface and how much stromal fibers are remaining. And if you are in, later, like 6 months, 1 year after that, it's absolutely difficult, very difficult to find out where is that interface. It's barely visible. Visual acuity, if the eye has a potential of 6.6, it will reach 6.6. 6.6 or 6.9. It is very, very common to see good vision after DLK patients. Yes, we do come across by some weird kind of astigmatism, like this patient had high myopia and high astigmatism, and we had to use a scleral contact. And sometimes you see those posterior DM folds if you have taking care of advanced cone, but this also tend to faint off, and after 6 months or 1 year, it doesn't cause much difficulty in the vision. Apart from K-conus, I enjoy doing it for corneal dystrophies, very handy for infections and scars where you don't know how deep it is. Initially, I never used to talk much about DLK, and the reason for that was I always thought the great DLK surgeon is the only one who can do a good big bevel Dalk. It's only 3 years back when I had to present a DLK, I reviewed all my cases and found that the outcomes are pretty good. Rather, when I talked with the various surgeons like Dr. Rasik Bihari Vajpayee, my friend Rishi, my DLK guru Paras, most of them, majority of them are manual Dalk. In fact, in India, only 1/3 of the corneal surgeons, they do a big bubble Dalk. There has to be a reason for that. There are enough studies, as Bhaskar also mentioned, that where we have seen that both manual DLK and big bubble Dalk, the visual outcomes are equivalent, whether it is a UCVA, BCVA, keratometry, astigmatism, all are equal. Yes, if you see the first 1 year, the visual acuity may be slightly better, but there are studies which say that difference is also insignificant. Another comparative study, people have studied hysteresis, reflectivity, densitometry. This all are same in both big bubble as well as manual DLK. If you have an inadvertent trephination, the manual DLK is lifesaver. You can still go ahead with DLK, don't need to convert into PK. In fact, so overall, if you think about any corneal, any complication in DLK as a trainee or as a learner, all those perforation, majority of them are out if you keep this bubble story out. So to conclude, for me, manual DLK and bubble DLK are two different techniques of doing the same thing. It's just like you have a stop and chop or four quadrant technique, and this manual DLK is a minimal learning curve. This surgery was done by my fellow first year into her practice, just out of her fellowship, and she could do a DLK. So if you have a PK skill set, manual DLK can be easily done. Predictability is very high. last these 10 years, there were only 1 or 2 cases that I had to convert PK, because that also, scar was very deep. For DLK trainee, I think you can straight away go ahead with, do your DLK, manual DLK, see after 15-20 cases, so that you can see your own post-ops, and then you can think if you want to really shift to big bubble DLK. I will leave with these 2 cases. The first case was sterile med, and the second was post archiectasia. These kind of patients, manual DLK is the only thing which will help you to do a actual DLK. So in lower video, you can see I'm removing these stromal fibers piece by piece. So it's like a pizza pie, it can come out. And in the upper one, so the whole stroma is removed concentrically, manually, by step, and then you go ahead and do your routine suturing in DLK, and the results are pretty good. So thanks so much. This is all from my side.
That was nice, Dr. Vikas. Shresh, can you take the first question?
Thank you so much, Dr. Bhaskar and Dr. Vikas, for wonderful talks and videos. Always a pleasure listening to both of you. And yes, while the construct of this topic might have been a debate, not always it's actually a debate. And I'm sure all of us use both techniques interchangeably. While even those who are in favor of big bubble, I'm also one of them. But I would probably attempt a big bubble in most cases, and then if it's not successful, switch over to manual. And similarly, there may be some cases where with a very thin cornea, the last ones like a pseudocornea, which Dr. Vikas was showing, where we would obviously not attempt a big bubble and go for a manual. But first question to Dr. Bhaskar, is there any way where you decide any criteria that you keep in mind that this is an eye where I will try a big bubble first and then go to manual, or these are sets of eyes where I'll directly go for a manual dissection?
I mean, I would unless there is a DM perforation, like a history of eye drops, kind of a thing, or it's in an infection, we have glued it and it has then formed a scar, where we know there is probably a breach of the DM, where you don't want to do a manual, where you probably also want to leave a little bit of stroma in that area. So those are the only cases where I would not do a big bubble DALK. Otherwise, I would attempt it, like I said, and if I get it, I would go ahead with it. The advantage of attempting it is at least that stromal emphysema and the presence of the air in the deeper layers gives you a very good visible clue telling you how much of stroma is still there. That way, even if you're doing a manual DALK, then the Rishi's technique of groove and peel, where it's like almost like an onion, you can kind of keep going till you reach a plane where your instrument enters in very easily, or you're able to see the shining DM, and it kind of peels off, where you would probably not use the crescent. The only worry that I have with the crescent is invariably in the initial stages, you tend to have slightly different planes. And when you're doing a manual, it is the tissue feel is important. As you keep doing numbers, you will realize once you put your instrument or spatula in, the ease with which the spatula goes in kind of gives you an idea that you are still superficial or you are reasonably deep as such.
Wonderful, sir. I completely agree. And of course, attempting a big bubble also gives you that stromal emphysema, like you highlighted, which gives you a nice idea about how deep you are in your dissection. To Dr. Vikas, I mean, again, I've always known that you say that you directly go ahead with manual in most of these situations. And you do show some wonderful post-op pictures, ASOCTs, where, the big challenge, I think, for most of us when we think about manual versus big bubble is when we do a big bubble, we feel that your plane is obviously it's uniform. You cannot have variable amounts of thickness, and it's a very uniform plane. Whereas with stroma, the only concern with manual is, will we have differential thickness? If we have a uniform 30 micron, uniform 50 micron, uniform 60 micron, I think the visual impact is going to be less. Especially with keratoconus, where majority of our cases are keratoconus, having a very thin cornea in the center and a relatively thicker mid-periphery, how do you ensure that you are able to get a very uniform stromal bed like you are showing in many of your cases?
Yeah, Shreya's right. Even I had this thing in my mind, but practically it doesn't make any difference. If you see the cornea also, it's not that cornea is uniformly same thickness. It's not that it's 600 in the periphery and 600 in the center. It's not like that. So what I have felt that it hardly matters. So suppose in the center you have 50 microns and the periphery you have say 70 microns, 80 microns, hardly matters. And this particular differential, what you're talking about, suppose when you see 6 months down the lane, 8 months down the lane, it's hardly visible because it's only 50, 70, 80 microns, and then you have this 600 microns thick cornea, right, which settles down. So it hardly matters. How do I make sure which plane I am in? If while you are dissecting, if you have seen the resistance, you are in the superficial. If your resistance goes down, that means you are coming the posterior stroma. Is the central 6-7 mm, if there you have got a good decent dissections, absolutely fine. There have been few instances where I had perforation in the periphery, and where periphery, another side of the periphery was not dissected much, and I left. So differential was 50 here and 120 there. Even then it doesn't matter much as far as that. So I'm yet to see a patient where I thought, oh my god, maybe I wish I would have done a big bubble here. So I think that practically that doesn't make much difference. And then it depends. If you keep on doing it, you get a hang of that. You know that you are in posterior stroma. You know that which area you are in. And then it hardly matters. Most of the times where you are starting from, that area slightly becomes thick. So you know that this area will be thick. So you ensure that once you have taken out your third layer, there also you dissect those stromal fibers. But practically, I think clinically it doesn't make much difference.
If I could just
Doctor,
add a point,
Yes.
Shreyas,
Yes.
it's important also to have the verticality of the edges. Most of the time with Dalk, you actually end
Right.
up having a shelving edge where again your graft house supposition becomes a bit of an issue, especially if you're doing a manual Dalk and you still have a little bit of a residual tissue and you're using a therapeutic grade tissue because you feel your endothelium is not required. So that is significantly AD matters. This bed is not as good. So you need to be very clear that you are able to maintain your anterior thing. So for that, the verticality of the edge is definitely important. And if you are deep enough, generally, even in the technique that Vikas showed, as you kind of peel off, you will really not need the crescent. You will probably be able to separate it even with a spatula, or it will actually peel off by itself. So if you reach a stage where it is kind of peeling off, then it is in the same plane because your collagen lamella is in the same plane. That's why it is peeling off. So you will have a reasonable contour which is matching the periphery. It's only when you are cutting that you might have a slight difference with respect to the planes in the center as compared to the periphery.
True, I think that is very important. That's why in keratoconus, I always just mark it. It's not that we refine it, just mark it and then use this 250 or 300 microns to ensure that it is vertical. That is a very important point.
And the
Doctor,
other thing was dissection, you have to be make sure that you are a hypotonic eye. You have to make sure that it is hypotonic, otherwise you'll end up with a perforation. Because even if it's a sharp instrument, if your AC is shallow, AC is shallow and the eye is soft, it will push the DM down rather than having an entry into the anterior chamber.
if there is
Very extremely valid points, sir, and both of you. Just a word for the audience. Although it is a debate, and if it were to looking at visual outcomes, at least a couple of large studies coming out of Italy, which have shown that when we compare a big bubble and manual Dalk at 3 to 5 year outcomes, they have shown that the outcomes, visual outcomes, are similar. The rapidity of visual recovery seems to be a little better with the big bubble than what we are seeing with the manual Dalk. And I think that's kind of the experience of most surgeons present here, where we are doing both big bubble as well as.
So generally around 6 months would be the time frame. After 6 months, you would probably not have a difference. Even when you have left about 100, as long as the interface is not irregular, it is uniform. Even with 120 microns, you might end up with a 6.6 vision. You can think of it in terms of DSEC. Yes, some of them end up with 6.10, but some DSECs where you have 120 microns of stroma sitting there still ends up with 6.6 also. But the number that reach 6.6 is more with DMEC as compared to DSEC. Unless you are looking at ultra thin DSEC. So if your Dalk residual tissue is less than say 70-80 microns, then it's kind of going to be similar. It's only a question of maybe a few months time that you would want to reach that best visual acuity.
So Bhaskar, I say, I think if you keep on
The voice is breaking, sir.
it, ultimately you reach a point when where the so I think those kind of tissues, it hardly matters. Even in first week, first month, you will see that stroma is absolutely clear.
Supposing there's a lot of interface haze, when would you decide to do a PK or a repeat Dalk, Dr. JK? You're muted.
Yeah, interface phase we don't get it after surgery. You get it before surgery. I mean, already there is a high drop, something like that. Some or a deep stomach scar when you are doing manual DALK, you are not able to remove something like that. But the post DALK interface phase is very, very, very rare complication. As far as unless there is a vascularization, not a follow-up patients are not following up, they might have lost or follow-up come back a few years. It's a lot of vascularization in the interface. That is the only condition we had interface case where we repeated the DALK and they're doing that.
Another potential area of, and probably I'll direct this question to Vanati madam, that where manual we would prefer over a big bubble is in the case of active infections when we are trying to do a therapeutic DALK as such, in especially Acanthamoeba, certain functions, infections which are still not reached the DM. What would be your suggestions on that, madam? How do we achieve a DALK in those cases with active corneal infection?
Thank you, Shreyas. I think the decision to do a therapeutic DALK is when the infection has become quiescent. So that's going to be your leading indication that you have controlled the inflammation to the maximum possible level here. So which means you're looking at a healing stage of the infection here. And you also do not want the posterior stromal involvement. So your infection needs to be contained within the anterior and mid stroma for an effective therapeutic DALK. But all said and done, I think the haze in a therapeutic DALK is always much higher than the DALK done for optical reasons here. So getting a 6.6 in most of these cases, even after your infection is well controlled, is going to be challenging here. You'll probably land up getting 6.18, 6.12 in the best of hands here. And I think both the techniques have their own plus and minus points here. And what is more challenging in both a manual and a big bubble DALK is the post-DALK astigmatism. I think astigmatism management is one thing which always tends to be a spoiler in a well-done DALK in both the scenarios here. And if that is contained and we take care of all those wonderful points which both speakers highlighted in a very nice manner, I think that is when I think after 6 months, it really doesn't matter what technique you have done.
Thank you.